So this patient's present with, there's a triad of manifestations. There is a triad of manifestations like painless hematuria. Painless hematuria, which is by far the most common presenting symptom in a patient of RCC, and painless hematuria, as long as it has not been proved otherwise, is renal cell carcinoma. If not proven otherwise, painless hematuria is because of RCC, as long as it is not proved otherwise. Then pain in the, so the most common, around 50 to 60% of patients with RCC present with painless hematuria. Then comes pain in the costovertebral angle, which is the second most common feature, which is around maybe 30-40% or 25%, whatever it may be. And finally, lump and pain in the loin region of the abdomen. So these are the triad, these three forms, these are the three most common symptoms or triad of manifestations that a patient of RCC present with. And out of these three, MCQ a question korte pare. এই তিনটের সঙ্গে আরেকটা দিয়ে দিল, দিয়ে বললো which is the most common clinical manifestation in a patient of RCC. So the most common is painless hematuria. So that's why I have put hematuria right at the top, at the apex. আর বাকি দুটো হচ্ছে pain in the costovertebral angle, painless hematuria পরে আসে pain in the costovertebral angle, which is followed by abdominal lump and pain in the loin region of the abdomen. Okay, these are the main features, the triad of manifestations. Other than that, you have constitutional symptoms like fever, weight loss, malaise, etc., etc. They are like common to more or less all tumors. But when we talk about RCC, remember these three: hematuria. That's why I'm beginning with this three: hematuria, painless hematuria. Painless hematuria, as long as it is not proven otherwise, is because of renal cell carcinoma. Then this is painless hematuria is followed by what? Pain in the costovertebral angle, which is followed by lump and pain in the loin region, lower region, loin region of the abdomen. This is your loin region of the abdomen. Okay. Remember this three. Ekdom exam point of view theke ja ja asche. Now starting the topic, it's a brief introduction. Remember, just remember, it's also called adenocarcinoma of the kidney, and RCC constitutes around 85% of all renal cancers. Can you name a cancer which happens in younger age group? A renal cancer in pediatric age group? Wilms tumor, also known as nephroblastoma. So those are not so common. So in adult, the most common, not only adult, the most common tumor in kidney by far towers the rest of the tumors that occurs in the kidney, and that is renal cell carcinoma, which constitutes around 85% of all cancers in the kidney. Okay. Obviously seen in elder age groups around 6 to 7 decades of life. Males are a little more commonly affected as compared to females. Okay, males are a little more commonly affected as compared to females, and previously it was called as hypernephroma because the cells in the cortex, the clear cells in the cortex, were thought to arise from the adrenal cortex. Okay, from the adrenal glands. That's why it was previously called as hypernephroma. Just remember these points. Remember the age group and the gender predilection. Males are more commonly affected, and elderly age group 6 to 7 decades of life, and RCC by far is the most common tumor in the kidney. But remember those triad of manifestations, painless hematuria. Again I'm telling you, এটা কিন্তু question আসতেই পারে. Painless, last, not this batch, previous batch had a question on RCC probably. So renal cell carcinoma is the triad of manifestations are hematuria, pain in the costovertebral angle, and pain and lump in the loin region of the abdomen. Out of this, painless hematuria is by far the most common presenting symptoms. Then you get the general features. Okay. So coming to predisposing factors, more or less similar: smoking, tobacco smoking, prolonged exposure to polycyclic hydrocarbons, then exposure to lead, asbestos, coal tar, etc., etc. Then adult polycystic kidney disease. Adult polycystic kidney disease is a predisposing factor for RCC. Then chronic renal failure, hemodialysis associated kidney diseases. Hemodialysis associated kidney diseases can give rise to renal cell carcinoma, obesity and hypertension. Obesity, hypertension and VHL. Have you heard of VHL? Von Hippel-Lindau. Von Hippel-Lindau disease. Von Hippel-Lindau disease. Where what happens there? Patients develop cerebellar hemangioblastomas, retinal hemangiomas, etc., etc. That is called VHL. So patients with VHL disease can also develop RCC, and you will see when we talk about the most common variant, which is the clear cell variant of RCC, there is mutation of the VHL gene at chromosome 3. So mutation in the VHL gene in chromosome 3 is responsible for 98% of sporadic renal cell carcinomas and 2% of familial carcinoma. VHL gene is very important. Okay, so when we discuss all the variants, we will be talking about it. Okay, so I have already mentioned the genetics of RCC. I'll be coming to that, but just know VHL, von Hippel-Lindau gene. Von Hippel-Lindau gene is most commonly in which one? Clear cell variant. In clear cell variant. So this VHL gene is present in chromosome 3, 3p12 to 3p26, spanning that area of chromosome 3 is the VHL gene. So it can either be deleted, or there can be loss of sequence, whatever it may be, or there can be hypermethylation or somatic mutation which cause inactivation of the gene. So what VHL gene does, you know, VHL downregulates a protein called HIF, hypoxia inducible factor. So when in physiological state, VHL downregulates a protein called HIF, hypoxia inducible factor. So when VHL is mutated, the hypoxia inducible factor is upregulated, resulting in what? Cellular growth and angiogenesis. Cell growth and angiogenesis are prerequisites for development of cancer via various growth factors. For example, platelet-derived growth factor, insulin-like growth factor, TGF-beta. So VHL gene normal physiological state ki kore, it downregulates. It downregulates hypoxia inducible factor. It downregulates hypoxia inducible factor in physiological state. So if VHL is mutated, that means it has gone into a state of pathology. It's in a pathological state. So the physiological state, if it downregulates HIF, then what will happen if the VHL gene is downregulated? VHL will be upregulated. So VHL will cause what? Increased cell growth and hypoxia, proangiogenesis and increased cellular growth via production or via transcription of various growth factors like platelet-derived growth factor, TGF-beta, insulin-like growth factor, etc., etc. That's how VHL acts. And remember, at least the VHL gene must be remembered. You must remember the VHL gene because VHL gene is associated with the most common variant of RCC. Porikhay jodi question ashe, they will definitely ask you about the clear cell variant. So you should know about VHL gene a little. Any questions can be asked. Examiners are depend korche who asks questions. So if this ask, you should be in a position to write about it. So please note about VHL gene. You know why I'm specifying so much on VHL is simply because of the fact that VHL is associated with the most common variant of RCC, that is the clear cell variant. And clear cell variant question, there's every possibility if renal cell carcinoma is asked, 100%, 110% sure they will ask about the most common variant. Mind it. Okay? Then trisomies of 7, 16, 17 and loss of Y chromosome, that is seen in the chromophil variant or the papillary variant. That is seen in chromophil variant or the papillary variant. At least you should remember, if you can remember the next one also, trisomy 7, 16 and 17 and loss of Y pattern and the loss of Y in male patients. Obviously, loss of Y will be lost only in males because women don't have Y chromosome. Okay, so at least remember the VHL has to be remembered, and if you can remember the next one, that is also fine. Trisomy 716 and loss of Y in male, which is seen more commonly in the papillary variant or the chromophil variant. And this chromophil variant is one of those variants which has the worst prognosis. The chromophil variant has the worst prognosis. Anyway, I'll come to that, but I'll be concentrating more on the clear cell variant. Okay. A schematic representation, which what I have just mentioned, this is from the Robbins, a schematic representation, which I have just mentioned about the VHL gene and the 716, 17 and Y. Okay, I'm not getting into the details of it, just remember the names. Nobody will ask you in exam about details of the genetic mechanism that takes place, just mention them. So, there are 4 variants of clinical significance. There are 4 variants which are of clinical significance. The most common is the clear cell variant. Then you get the papillary or the chromophil variant, the chromophobe variant, which has the best prognosis. Chromophil has the worst prognosis. Chromophobe has the best prognosis. Check করছিস ঠিক বলছি কিনা? হ্যাঁ ঠিকই বলছি, don't worry. Chromophobe has the best prognosis, and then collecting duct of Bellini. That's one more variant. Out of this, which is the most common? Clear cell variant. So when you talk about the variant, you should also know the cell of origin. You can't just mention that it arises from the kidney. You must be very specific about which cell in the kidney they arise from. There you have to pinpoint the cell of origin. So the clear cell variant arises from the proximal tubules. Cortex cell proximal tubule theke, the proximal tubules of the cortex. That is the clear cell variant. After that, you have the papillary or chromophil variant. Papillary or chromophil variant arises from distal. প্রথমটা proximal হলে পরেরটা হচ্ছে distal tubule in the cortex. The epithelial cells in the distal tubules. Then you get the chromophore variant. You get the chromophore variant arising from the intercalated ducts. And finally, the collecting duct arises from the collecting duct in the medulla. So at least the cell of origin must be known. The clear cell variant to jantei hobe from the tubular epithelial cells in the proximal tubule of the cortex. Eta to jantei hobe. Baki gulo jante paro. Try to know it. Try to know it. Ami to bole dicchi, this is very important from the exam point of view. Renal cell carcinoma is very, very, very important from grossly tumor ta dekhte ki rokom lage. How does the tumor look like? Grossly ki rokom dekhte lage tumor ta. Which part of the kidney is involved? Not the cell, the part. Generally egulo hoy unilateral, mane one side of the kidney and unipolar. Either the upper pole or the lower pole is involved. Either the upper pole or the lower pole is involved. So poles are most commonly involved, generally unilateral, okay, and solitary. Generally unilateral and solitary. The spherical lesion, partially encapsulated, spherical lesion, spherical lesion, partially encapsulated and bright yellow to grey white, cut section grey white, and they have a bright yellow appearance. Why bright yellow appearance? Because they contain fat. Because they contain fat. Bright yellow appearance keno hocche? Because of the fact that they contain fat. Okay? There can be areas of necrosis and hemorrhage. These are all important. There can be areas of necrosis and hemorrhage. Invasion can be seen. Invasion of pelvis, calyces and adjacent structures can be seen. But invasion of calyces and pelvis, calyces and adjacent structures are more common with chromophil variant rather than clear cell variant. Okay, and sometimes there can be invasion of the renal veins. This is a characteristic feature of renal cell carcinoma of both clear cell variant and chromophil variant is invasion of the renal vein. So from renal vein they can go to the inferior vena cava, and from inferior vena cava they can straight go to the right atrium, the right side of the heart. Mind it, renal vein, there is a propensity of this renal cell carcinoma, there is a tendency of this renal cell carcinoma is to invade the renal vein, and from renal vein they can go up to the inferior vena cava, and from inferior vena cava they can go to the right atrium, the right side of the heart. So this is a characteristic feature of renal cell carcinoma. So when we cross a nephrectomy specimen, it is prudent that we check for the invasion of the veins. We have to feel grossly, we have to feel whether there is any tumor foci in the renal veins or not. It's important because not all RCCs will do, but some of them will do, and if they do, we need to make a mention of that because the prognosis is not good. Once the renal vein is invaded, renal vein theke it can go to the inferior vena cava, and from inferior vena cava it can go to the right atrium or the right side of the heart. Okay, mind it, renal vein, ei jinishgulo point gulo kintu mathay rakhte hobe. Each and every point is important. The unilateral arise predominantly from the poles and dekhte ki rokom lage, spherical, golden yellow or bright yellow in color because of presence of fat, because of presence of lipids. They are bright yellow in color. There can be cut surfaces, there can be areas of necrosis and hemorrhage. Invasion of the pelvis calyces can be seen, and one of the most important examiners will love to ask you these questions about this renal vein invasion. What is the characteristic feature of RCC when it comes to say spread? So very important is the invasion of the renal vein. So invasion of the renal vein, from renal vein they can go up to the inferior vena cava, and from inferior vena cava to the right atrium. Okay? Remember these points, I'm telling you again and again. Okay? So this is basically the tumor here. This is one of the poles. This is the tumor. Okay? Therefore the cut surface, they have a variegated appearance. They can be solid as well as cystic areas, a variegated appearance with solid and cystic areas, and predominantly এগুলো দেখেই বোঝা যাচ্ছে there are areas of necrosis and hemorrhage, isn't it? There are areas of necrosis and hemorrhage. এগুলো প্রথমবার দেখে I know it becomes difficult, but because we have been doing this for years, it has become easy for us as compared to you. So but at least remember these points, and at least কিরকম দেখতে লাগছে একটা variegated appearance পড়লে এখানে solid cystic areas পাওয়া যেতে পারে. And see, these are all hemorrhage. এই যে লাল 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 এগুলো কি? These are all hemorrhage, and এইগুলো probably এইগুলো তো definitely these are areas of necrosis here. মানে grossly খুব easily দেখা যাবে. Then comes papillary carcinomas. Papillary carcinomas can be multifocal and bilateral. Unlike clear cell carcinomas, which are generally unifocal and unilateral, papillary carcinomas can be multifocal and bilateral, and what it is associated with dialysis. Dialysis associated cyst can give rise to papillary carcinomas. Dialysis associated cyst can give rise to papillary carcinomas. Chromophore variant, just remember it has light brown on cut surface, it is light brown, and then Bellini duct. Sharp kota kintu they can present with areas of necrosis and hemorrhage. All of these tumors can present with necrosis and hemorrhage. And out of all the 4 variants which I have mentioned, the best prognosis goes to this one, chromophore variant, and the worst prognosis is papillary carcinoma or chromophil variant. It has the worst prognosis. So this is gross. Now coming to the light microscopic features. I'm just teaching you from the exam point of view because we don't have enough time. Light microscopic variant. So the cells are round or polygonal in shape, round or polygonal in shape. Why the cytoplasm is clear? Why is the cytoplasm clear? Because the fat gets washed away during paraffin embedding. যখন আমরা histopathological sections বানাচ্ছি না, the fat gets washed away, and that is the reason why you get abundant clear or sometimes granular cytoplasm. So round or polygonal shape with abundant clear or granular cytoplasm. ঠিক আছে? And these cells are surrounded by thin walled blood vessels. This delicate, a fine network, these cells are surrounded or they're separated by a fine network of thin, delicate vascular channels giving rise to a chicken wire appearance. I haven't mentioned the new additions, all the new additions mention it. So this round over or polygonal clear cells, they are separated from by a thin branching vascular channels giving rise to an appearance which has been equated to chicken wire. Fine vascular channels equated to chicken wire. And the growth patterns are solid, trabecular or tubular. Solid, trabecular or tubular. So look at this. Look at this. These are all the clear cells. These are all the clear cells. What is this? এই জিনিসটা কি? What is this? Huh? This is blood vessel. আর এই যে cells গুলো দেখতে পাচ্ছ, these are the nuclei, and all the cells are clear because the fat has been, the lipid has been dissolved during histopathological sections. The cells have been, the cytoplasm has been cleared off. Okay? Is it clear? Then comes the papillary variant, which is the worst prognosis. Papilla, as the name suggests, they are arranged in papillary configuration. The growth is papillar. The growth is in a papillary configuration, and this kind of growth is known as papillary configuration. This kind of growth, these structures are all papillar. These are all papillar. Okay, so they are formed of columnar or cuboidal cells, and their growth pattern is papillary. And the core of the papilla will have interstitial foam cells or psammoma bodies. Interstitial foam cells or psammoma bodies. Then comes the chromophobe variant. This chromophobe variant looks a bit like clear cell, isn't it? They look a bit like clear cell. They're all pale eosinophilic cells with a perinuclear halo. Pale eosinophilic cells with a perinuclear halo. In and around here, you can get those halos. Around the nucleus, you'll get those halos. Okay, pale eosinophilic cells with perinuclear halos. And finally, the collecting duct variant, they have a hobnail pattern. Anyway, I'm not getting into the details of this, but at least know that this variant must be right. Ye change korte hobe, battery কাজ করছে না. So the clinical features which I have mentioned, there's a triad of manifestations, and I'm pretty sure by this time you have by-hearted it. I'm pretty sure by now you have by-hearted it. Can anyone say without looking? Painless hematuria, not hematuria. Painless hematuria. Painless hematuria, as long as it has not been proved otherwise in an elderly male or a female, is because of renal cell carcinoma. What's the next one? Huh? Pain in the costovertebral region and lump and pain in the loin region of the abdomen. এই তিনটে কিন্তু মাথায় রাখতে হবে, এমসিকিউ এ বারবার এই কোশ্চেনটা কিন্তু জিজ্ঞেস করে। Okay, other than that, which this point I have mentioned already. I have already mentioned this points. Actually, you are correct. This is working, this battery, otherwise lal eta asto na. Then you get fever, malaise, weakness, weight loss. These are the other constitutional symptoms, but the triad of manifestations that must be known. Now, renal cell carcinoma is considered as a great mimic of medicine because of the various symptoms that it produces. because of the various symptoms that it produces, this RCC has been called a great mimic in medicine. Why? What are the symptoms they produce? Paraneoplastic syndromes. Paraneoplastic syndromes. By now you know what is a paraneoplastic syndrome. Hanana, you have heard of it. You know what are the various paraneoplastic syndromes. I have taken the class. So, what are the various paraneoplastic? Why does this paraneoplastic syndrome occurs? It's because of the ectopic hormones these tumors tend to produce. So, what are those? What are the various hormones they produce, and what symptoms arise because of such hormone production? Depending on the hormone they produce, the symptoms arise. The symptoms arise accordingly. So, what are the hormones produced? If they secrete renin, patients present with hypertension. তারপরে erythropoietin যদি secrete করে তাহলে polycythemia, right? Parathormone like peptide giving rise to hypercalcemia. Masculinization, feminization কেন হতে পারে? Because of gonadotropins. Cushing syndrome হতে পারে because of ACTH. Other than that, you can get dysfibrinogenemia, hepatic dysfunction, leukemoid reactions, eosinophilias. So these are the various symptoms that it produces if the tumor produces ectopic hormones, resulting in paraneoplastic syndrome. So mind it, RCC is notorious for producing paraneoplastic syndrome. It's considered to be one of the greatest mimics in medicine. It's simply because of the various hormones, the ectopic hormones it produces, giving rise to paraneoplastic syndromes. And depending on which hormone it produces, the symptoms should arise accordingly. Erythropoietin hole hobe polycythemia, jodi renin hoy hypertension, Cushing ACTH hole Cushing syndrome, parathormone like peptides hole ki hobe hypercalcemia, gonadotropins hole ki hobe masculinization or feminization. Other than that, you get dysfibrinogenemia, your hepatic dysfunction, Cushing syndrome, leukemoid reactions, eosinophilia, etc. etc. Okay? Mind it, paraneoplastic syndrome, jodi RCC ashe, please make a mention of paraneoplastic syndrome. Ki symptoms other than that are kibhabe present korte pare? There are certain clinical signs. The patient can also present with the following clinical signs. For example, edema of the lower leg. RCC patients presenting with edema of the lower leg. It's because of extension of the tumor. যদি বলেছি না renal vein থেকে inferior vena cava যেতে পারে, so inferior vena cava থেকে right atrium যদি যেতে পারে, inferior vena cava যদি obstruct করে, it can present with what? Edema of the lower leg. Then left-sided varicocele. কোথায় হতে পারে? Because of obstruction of the left testicular vein. The left testicular vein drains directly into the left renal vein. And if the testicular vein is obstructed by the tumor embolus, the patient can present with a left-sided varicocele. Pathological fractures hote pare with extension of the tumor into the pelvis, the femur and various other bones. Patient can present with pathological fractures. Or other than that, depending on which side it has gone, lung, skin, gingiva, buccal cavity, nasal cavities, skin, soft tissue, wherever it has gone, sometimes the patient can present with following features depending on the site of metastasis, that is around 5%. So এই পয়েন্টগুলো কিন্তু তোমাদেরকে মাথায় রাখতে হবে। Okay? So last, spread of tumor. How does the tumor spread? Local spread, local, lymphatic and hematogenous. Local কি হতে পারে? Renal capsule and perinephric fat and renal vein. Renal vein থেকে inferior vena cava and right side of the heart, so ওটা renal vein invade করলে হবে। Local. Then you get lymphatic to para-aortic nodes. Lymphatic is to para-aortic nodes. And then hematogenous. Hematogenous এর মধ্যে lungs এ যেতে পারে, bones এ যেতে পারে, liver, skin, etc. Various sites. So remember these three at least. এইভাবে হেডিংটা অন্তত এইভাবে দিও, local spread, lymphatic spread and hematogenous spread. আচ্ছা, এবার একটা কোয়েশ্চেন করতে পারে ল্যাবরেটরি ইনভেস্টিগেশনস। সব এতে কিন্তু ল্যাব ইনভেস্টিগেশনস জিজ্ঞেস করবেই খুব কমনলি। সো ল্যাব ইনভেস্টিগেশনস গুলো মাথায় রাখতে হবে। হিমোগ্রাম যদি করো, ব্লাড কাউন্ট, তাহলে এরিথ্রোপয়েটিন ইনডিউসেস পলিসাইথেমিয়া, আরবিসি কাউন্ট বেড়ে যাবে। ইউরিন অ্যানালিসিসে hematuria, no malignant cells generally in RCC. urinary microscopic examination করলে কিন্তু malignant cells দেখা যায় না। You may not find a malignant cell if you take urine from a patient of RCC, centrifuge it and look for malignant cells under microscope, you may not find it. But what you can consistently find is hematuria, painless hematuria, blood passing in urine. So hematuria is an important finding, one of the most important findings. If you do blood biochemistry, serum calcium levels will be high and deranged. They can be deranged renal function tests or liver function tests. Okay, and imaging techniques. Imaging technique আমরা কি করব? Ultrasound abdomen করলে কিন্তু আমরা sometimes tumors are identified incidentally. Patient does ultrasound for something else and incidentally, fortunately bolte paro, unfortunately because the patient should not have it. Fortunately, why I'm saying it fortunately is because it has been discovered at an early stage. Maybe it is discovered at an early stage. Okay, so ultrasound abdomen করতে গেলে especially KUB, kidney urinary bladder যদি করি আমরা, অনেক সময় পেশেন্টের মধ্যে as incidentally symptoms নেই কিন্তু incidentally we find RCC. Then IV pylography, renal veins, IV pylography and renal arteriography and bone scan. Bone scan to onek pore ashe. Bone scan comes later when if there is pathological fracture, metastasis in a proven case of RCC. আবার অনেক সময় কি হয় জানো, patient presents with a fracture, patient do not even know they have RCC and অনেকবার এরকম পাওয়া যায়। Many a times this happens, patient presents with fracture, একটা biopsy করলো, একটা scan করলো, scan করে দেখা গেল there is a tumor, তারপরে biopsy করলো, biopsy করে দেখা গেল it's a RCC, এরকম অনেকবার হতে পারে। So these are the investigations which you need to know in and out.